Diabetes mellitus. Remember, there's type 1 and type 2. When we're talking about children and juvenile diabetes, that is really type 1. Type 1 differs from type 2 in that we have no insulin. Typically, there has been a total destruction of those beta cells in the pancreas, so the child is not able to make any insulin. Now, this usually is an immune-mediated response, which means their own immune system. It's kind of this autoimmune destruction of those beta cells. And typically, we see it usually after a viral illness. Then the immune system will turn on the pancreas and destroy all those beta cells, and these kids have no insulin. And that's significant to remember that difference. They're usually children or young adults, and they're thin. It's unrelated to weight. It's only related to the destruction that their body has done to the pancreas. Idiopathic, meaning it's not immune related, and that's not as common. Now, with your type 2 diabetics, these are mostly going to be adults, and unfortunately we're starting to see some kids and a fair amount of teens with this due to obesity. But in type 2, we have insulin resistance, which means your cells aren't very good at picking up the insulin, which is the only way they can get the glucose inside the cells. Remember, the insulin has to pick up the glucose, and then the cell can pick up the insulin, but it can't get the glucose without the insulin in between. So we can give them oral, on type 2, we can give them oral hypoglycemics, which makes those insulin receptors on the cell kind of stand up at attention and look for insulins to grab. With your type 1, that doesn't work at all because there is no insulin to grab. With type 2, we can change their food. So they're not eating simple carbohydrates or high amounts of carbohydrate that absorb very quickly, and you get this sudden spike of blood sugar because of your food, and your body can't quite keep up with secreting enough insulin when you have those spikes of food. So we make them have more complex carbohydrates and always include proteins with those fats and proteins with the carbohydrates, so they don't absorb so quickly and have these spikes in the bloodstream. A little bit more constant level being absorbed, so hopefully the body can keep up. Again, doesn't work with the type 1 because they make no insulin. Doesn't matter how much or how slowly the sugar is entering the bloodstream. They can't get it into the cells. Exercise. With our type 2s, often they're overweight. Exercise actually helps with that insulin resistance. It helps those cells to be better at picking up the insulin, and it also uses up some of the blood sugar. The cells are working harder, so they need more sugar for metabolism, so more of that sugar in the blood gets used up. So very good with type 2. Type 1, it makes no difference on what they still have no insulin. So big difference between the two. Now, the pathophysiology, this is of type 1 diabetes. We have deficiency of insulin, and usually it's a total deficiency, total lack of insulin. So because of that, our glucose cannot get out of the bloodstream and into the cells. So our cells are having to do metabolism in less effective ways. They're not able to use the glucose that is the most, the best source of metabolism in your cells. And because that glucose can't get out of the bloodstream and into the cells, we see hyperglycemia, extra blood sugar, that sugar is stuck out there in the blood. Now remember, kids are really prone to these fluid shifts, so water is going to move from intracellular to extracellular by adding all this extra sugar, all these molecules of sugar in the blood. We've made an oncotic pull, so we're pulling water out, trying to dilute that water. So what you're going to see is cell and tissue dehydration. When our blood serum gets over a certain level, usually it's about 180, our kidneys are going to try and dump some of that glucose out, and you'll see glucose in the urine. Now, in the kidneys, we're trying to dump out glucose. We're also dumping out a lot of water to try and dump out that glucose. We said they're already cellularly and tissue dehydrated, and now we're dumping out extra water. So hopefully you're seeing an increasing problem here, and that's one of our cardinal symptoms, is this polyuria, peeing a lot. That's going to trigger thirst, and so they're going to be extremely thirsty. Polydipsia, another one of the cardinal symptoms. Now remember, the glucose can't get in the cells, so the cells are having to do other types of metabolism, and they'll start using proteins instead of sugars. When you metabolize protein, you make very acidic waste products, so we end up with acidosis as well. And then all of this lack of appropriate metabolism in the cells is going to trigger hunger, and so you'll see polyphagia. So those are the cardinal symptoms: polyuria, polydipsia, polyphagia, and it's usually with weight loss, because we're not able to metabolize normally. They're going to actually lose weight, and they're becoming increasingly dehydrated. Kids are very prone to ketoacidosis, DKA, diabetic ketoacidosis. Adults, it's possible, but it's not real common. Kids, it's very common. And this is because the body starts using those fats. As those fats are broken down, we make ketones. Those are our waste products that are very acidic. That acid is going to lower the blood pH. One of the things you're going to see that the body's trying to neutralize the pH of the blood by blowing off. Remember, our CO2 is also acidic, and so we can blow off hydrogen ions by blowing off just more CO2. So you're going to see deep, fast respirations. I was going to try and do it. I'm not sure I can. I won't. But these are called Kussmaul respirations. Sometimes you'll have a little sugary smell to that expired air as well. Now, potassium is a real problem. Electrolytes in general, because we've done all this fluid shifting around, and by adding those extra big molecules of sugar, though, we've changed the osmotic pull between cells and the serum. So as cells shrink, can't metabolize right, become acidotic, and we get cell death, some of those cells break, potassium is inside, it spills out. So we may not see an extremely low potassium because it's spilled out from broken cells. However, in reality, the potassium is decreased. And the other reason we may not see that is that extra hydrogen ion. Remember, H is a cation, H+, and potassium's also a plus. As you add all those extra H's, some of those are going to move into the cells and push out some of the potassiums, because we're going to always try and keep that equilibrium. So if you put cations in, you're going to spill them out. So your serums, your potassium levels aren't going to look all that decreased. They may even look a little high between the dehydration, so you just have this concentrated, everything in the blood is a little bit concentrated because we pulled out water, and the shifting, it doesn't look as bad as it really is. Now, I underlined this cardiac arrest as a potential problem. what I've seen several times when I worked at Children's in the Peds ICU is at a well-meaning adult facility, they see a kid come in with a high blood sugar, so they give them a nice big dose of insulin. The problem is when you change those molecules of sugar, we get all this potassium and hydrogen and electrolytes shifting going on, because remember, it shifted, and they can go into cardiac arrest. Our heart does not tolerate shifts of potassium. So when you're done with this program, if you're working in an adult facility and you see a new onset child with type 1 diabetes, call Children's Hospital. Do nothing. Don't do anything. Let a pediatric endocrinologist manage it, please. Okay, long-term complications. Both small and large blood vessels are involved, as well as your nerve cells, so neuropathy, and also the retinas of the eye. We have vision issues, so retinopathy. What happens is this glycosylation, so proteins end up deposited on the membranes of the vessels because of just the stickiness that happens from the extra glucose. And as you build up, it's sort of like in heart disease, you're building up plaque inside the vessels. Well, we're building up this sticky glucosey stuff and narrowing the vessels and making them stiff so that they don't have the nice normal stretch that they have. Happens both in your smaller and your larger vessels. Neuropathy is a similar thing, except it's that sheath, that myelin sheath on the outside of the nerves. It gets stuck on there, so it interrupts the nerve transmission, so you can get numbness, and the farther out into the periphery, the more problem we have with this. So your feet are typically where you're going to see these problems first. Nursing alert. Now we're jumping back to type 2 diabetes here. So particularly with a teen or something, if you see a lot of UTIs or vaginal infections, that's sometimes an early sign of type 2 diabetes. They're just running a little bit higher blood sugar. Takes their body longer to use up that sugar and get it into the cells, so they have this overall slightly higher blood sugar a lot of the time, and that allows for those UTIs and vaginal yeast infections to grow. Okay, our therapeutic management, and now I'm jumping back to type 1. We're going to give insulin. Remember, this kid doesn't make insulin, so we're going to give it. Insulin is always given sub-Q. Remember, those oral things don't work when you're talking about a total lack of insulin. So sub-Q insulin, and we can do this in many different ways. We can do the twice a day, mixing a short and intermediate acting. The problem with that is you have no control. So if the child decides to eat cake for lunch, well, hope that their intermediate acting one they got in the morning is going to cover it, right? Or if they decide to not eat lunch, then we're in even more trouble because they're going to drop low. So with kids, most of the time we'll go with multiple doses instead, and they use an insulin pen. It looks like a pen, and you kind of twist the back, which would be the clicker part of the pen, and it has numbers. The number shows up in a little box that shows you exactly how many units you're giving. So we tend to do multiple doses of regular insulin and not use the intermediate acting. So every time before they eat, we're giving them a little bit more insulin to cover what they're about to eat. Our goal is to get these kids on a continuous pump. So it runs with just a low level of insulin all the time to manage that basal metabolic rate, and then they look at what they're going to eat, calculate how many carbs are in their meal, and give the appropriate amount of insulin for that. So children, we usually do more frequent shots, and there is a little bit of research out there of trying to do insulin in other ways or do transplantation, but at this point that's not readily available.